I'm going to go ahead and get started since we just have an hour for this presentation. I'd like to introduce myself. My name is Grace Harrell. I am a board-certified anesthesiologist and pain specialist from Boston, Massachusetts, and it's my pleasure and honor to present the topic of chronic pain to my NMA family. I will be presenting along with Scott Petersen. So I will start, and he will have his section, and then I will wrap things up. A few housekeeping notes and disclaimers. I'm going to read this verbatim, forgive me. This program is sponsored by, and speakers are presenting on behalf of Pfizer and Eli Lilly and Company. The content is consistent with applicable local guidelines. The content is not approved for continuing education credit. Again, the content is not approved for continuing education credit, but I'm hoping that you learned something. A few housekeeping notes. If you have not already, please scan your conference badge. There are question cards if you need them. As questions arise, please jot them down, and we will have a formal question-answer session at the end. And lastly, and very importantly, you've got an evaluation form. Please fill this out because it will help the company with future planning for events. So please write your comments and concerns and future suggestions. Also, remember to put your cell phone on mute so you won't disturb others. This is our agenda. And here are our learning objectives. Again, I'm going to read, these are important, I'm going to read them verbatim. At the end of this program, we would like you to discuss the classifications, epidemiology, treatment guidelines, and unmet needs in the management of chronic pain. Describe the components of the pain pathway and key mechanisms of peripheral and central sensitization. Examine potential chronic musculoskeletal pain mechanistic targets under investigation. And lastly, review best practices in setting, communicating, and working with patients towards individual treatment plans in chronic pain. So I'm going to start things off with a brief lecture on pain, what it is, epidemiology, guidelines, the anatomy, physiology, and pathophysiology of chronic pain, and discuss the targeted mechanisms by which we currently treat chronic pain. As a disclosure, I'm a consultant for Pfizer and Lilly. So, first, we'll talk about understanding chronic pain. All of us know what pain is intrinsically. You know, things hurt. But just so we're all starting off on the same basis, I'm going to read the definition of pain that's promoted by the International Association for the Study of Pain. They put this out in 1979. They define pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Pain can be classified by its duration. It can be either acute or chronic. Chronic pain is typically defined as pain of greater than 3 months duration. Pain can be classified by its nature, nociceptive or non-nociceptive. Nociceptive pain implies damage to the tissue, either the soma, that is the body, tendons, muscles, ligaments, joints, or the viscera. Visceral pain, internal organs like intestine or heart or bladder. Pain can also be described as non-nociceptive. Neuropathic pain is an example of this. Neuropathic pain is pain that is caused by actual damage or pathology to the nervous system. A newer term for non-nociceptive pain is nociplastic. Nociplastic pain refers to pain that is due to abnormal pain processing. The organism is fine. There's no obvious injury or disease. The nerves are fine, but yet the person perceives pain, and it's thought to be because the pain processing system in that particular individual is somehow impaired. Examples of nociceptive pain would be the pain of arthritis, neuropathic pain, post-herpetic neuralgia, or diabetic neuropathy. Fibromyalgia is probably a classic example of nociplastic pain. But note that a patient with a particular pain syndrome may have components of all of these. They may have a somatic component or a tissue component, a nerve damage component, and also some processing deficits. In terms of the classification of pain, there's something to look forward to with ICD-11. The World Health Organization and the International Association for the Study of Pain has proposed, actually just in January of this year, a new diagnostic criteria for chronic pain. And here are the diagnostic criteria for chronic musculoskeletal pain. Can either be primary or secondary. These definitions and potential ICD-11 codes are useful and helpful because they incorporate pain as a complete experience, that it's multi-systemic in nature of varying etiologies. Now that we've discussed what pain is, how pain can be categorized, we can discuss treatment guidelines. A brief example of 9 treatment guidelines that have been published recently for either osteoarthritis or low back pain. You note that all of these treatment guidelines promulgate a multimodal approach to pain. By multimodal, they mean non-pharmacologic, pharmacologic, and interventional as needed. By non-pharmacologic, they include cognitive behavioral therapy, exercise, physical therapy, weight management. In terms of pharmacology, for most of the guidelines, the first drug of choice is either a non-steroidal anti-inflammatory drug or acetaminophen. Despite these treatment guidelines and best evidence, both patients and physicians are unhappy with pain care. A survey in 2006 that they surveyed 303 patients with chronic pain who were on opiates. About half of them felt they had little control over their pain, and more than half experienced breakthrough pain at least once a day. And physicians were very dissatisfied with treating patient pain. They felt that there was a lack of therapeutic options, and the subjective nature of chronic pain made it difficult to treat. So there are barriers to the optimal treatment of chronic pain. These are both patient, provider, and societally centered. Patient factors can be not believing that their pain can be managed effectively. There are adherence and compliance issues. Health system factors. The healthcare system could use some improvement with the emphasis on chronic, long-term, and preventive care as opposed to acute episodic pain, episodic care. And on the part of health professionals, there's not enough time. There are disagreements in the way that chronic pain should be managed. And also, often providers are not educated in pain mechanisms and pharmacology of pain. So to help remedy this, we're going to go back to school and review some pain anatomy, physiology, and we'll do a brief assessment of the pathophysiology of chronic pain. So this diagram probably looks familiar to you. Let's see if I can get my... Okay, my pointer's not working. Oh, there it is. There it is, okay. Oh boy. Okay. So as you remember from medical school, the ascending or input of the, I'm going to call it a nociceptive input, because pain isn't pain until your brain thinks about it. So a nociceptive input would be stimulated by the peripheral nociceptors. You've got mechanoreceptors, you've got thermal receptors, and chemical receptors. These are triggered, and they go to the dorsal root ganglion via myelinated A delta fibers or unmyelinated C fibers. From there, it goes to the spinal cord. The nociceptive signal crosses over and ascends via the spinal thalamic tract to the thalamus. And then you might recall the thalamus being called the relay station. From the thalamus, the signal goes to the cerebrum, cortex, where you think and acknowledge pain, but also to the limbic system. Should note that a lot of the processing of pain or nociception is in the spinal cord. I've described the ascending input from the site of injury through the receptor, through the spinal cord, up to the brain. There's also descending modulation of pain. A lot of that takes place in the spinal cord with serotonergic and noradrenergic neurons and interneurons that, particularly in the substantia gelatinosa, which are responsive to opiate drugs. We know that inflammation can be a source of pain, inflammation because of a disease state or inflammation because of injury. Inflammatory cells can promote mediators of inflammation, including nerve growth factor, interleukin 1 beta, interleukin 6, tumor necrosis factor alpha, and prostaglandin E2. These mediators of pain go to the receptor of a nociceptor and can cause excitation and sensitization. Excitation just means a transmission of the neural impulse. Sensitization in the periphery and also centrally just implies that it's easier. The neuron is more sensitive to discharge. Let's talk about nerve growth factor for a moment. Nerve growth factor is a key mediator of pain by direct action and indirectly. Nerve growth factor binds to tyrosine kinase A receptors that can promote the release of more mediators. Also, nerve growth factor can act on to trick A receptors on nociceptors and sensitize those. So it works in both ways. It can make the inflammatory cells release more inflammatory products, including more nerve growth factor. And then the nerve growth factor itself can bind to the nociceptor and causes changes there. The way it works is that it modifies ion channels and receptors to make the nociceptor more sensitive or easier to fire. It can increase the amount of receptors that are available to the site and also increase the ion channels to facilitate the transmission of a pain impulse. You can think of this as, in addition, it can decrease inhibition. So you can either, say you're in a car, you're driving somewhere, you want to go faster, you can either put your foot on the gas, or if you're a bad driver and have both the gas and the accelerator and the brake on, if you lift up on the brake, that will also make you go faster. So you can either increase excitation or decrease the inhibition to facilitate a pain impulse in the periphery. It does this, it can make long-term changes. It's simply, I will just briefly say that the nerve growth factor binds to the tyrosine kinase. It gets phosphorylated. Two of those complexes, called the dimer, gets invaginated into the cell and promotes transduction and translation of new protons, new proteins, new ion channels, and new receptors. Facilitation and increased sensitization can also happen in the central nervous system. Typical mediators are substance P, brain-derived neurotrophic factor, and calcitonin gene-related peptide. So we're just going to winnow down. You see the dotted box. So we'll blow that part up, and we'll see within the spinal cord that these substances can produce more excitation to facilitate the transmission of a nociceptive response. And it can also basically lift up on the brakes and inhibit the inhibition. So the net result is an increased strength of a nociceptive signal. So this is a review of what I've just said for the past 5 minutes. So, number one, you've got a tissue injury. Somebody cut you with a knife. You put your hand in the fire, whatever. You have inflammatory mediators that are released. These include nerve growth factor, interleukins, tumor necrosis factor, and prostaglandins. These excite the nociceptor. So number two, mediators that were just released excite sensitized nociceptor. Number three, because of what nerve growth factor does, it can actually retrograde signaling. And there's a feedback loop that when nerve growth factor is present, it enhances the production of more receptors and more signaling. In addition, neurotransmitter and ion activity is increased. And as you get more impulses from the periphery into the spinal cord and central nervous system, you get more central sensitization. So the net effect is to increase pain perception. So you have an injury, these mediators are sprinkled out, and it causes increased pain or increased nociception. So let's review how we currently treat pain, superimposed with what we know about the pain pathways. To review, we have the peripheral nociceptors, which go through the dorsal root ganglion into the spinal cord, up through the spinal thalamic tract to the thalamus, and then to the limbic system and cortex. Also, we have descending modulation from the brain and spinal cord to tamp down the pain response. The drugs we use today affect things either centrally or peripherally. Opioids work in the cortex and in the limbic system to change your affective response to pain. In addition, they enhance the interneuron transmission in the spinal cord. You all remember the substantia gelatinosa in the spinal cord. That's where opiates also work. Certain tricyclic antidepressants and serotonin reuptake inhibitors enhance the descending inhibition from serotonin and norepinephrine. Certain anticonvulsants, not all, decrease the pain signaling. They just tamp down the neuronal response. And of course, we've got nonsteroidal anti-inflammatories whose hallmark signature action is to decrease the production of prostaglandins. So with all that said, I'm going to introduce Scott Petersen, who's going to take us further.
Thank you, Dr. If I can avoid knocking down the stage. Thank you, Dr. Harrell. Hello, my name is Scott Petersen. I am a pain management physician assistant for Cleveland Clinic's Avon Hospital facility. What I'd like to do is I'd like to take the next few minutes and I'd like to discuss with you where we're looking into the future, how we're looking at treating chronic pain, what targets are under investigation. I also want to talk about the importance of the provider-patient relationship. We know that chronic pain is a chronic disease state. We know that it has devastating effects on people's lives. But what we're just finding out and what the research is starting to show is that your relationship with your patients in chronic pain and your understanding of the burden that they have is just as important to your patient as the treatments you provide, the medications you give, the referrals you make. So we're going to discuss the importance of that relationship between chronic pain patients and the people that take care of them. My disclosures, I have the good fortune to be a consultant for both Pfizer and Lilly, and I have no other financial disclosures. And as I mentioned, we're going to take a look at some of these targets under investigation, and we're going to talk about best practices in setting, communicating, and working with patients towards their individual treatment goals in chronic pain. So let's move on to what if. What if we had a way to treat chronic pain without the side effects of opioids? What if we had a way to use new receptor sites, new binding sites, new ways of taking a look at managing this pain and trying to get better control of chronic pain with fewer side effects? Well, fortunately, researchers are working on a number of these. And let's take a look at what we've got. We know that when an injury occurs, inflammatory cells create a number of mediators that act on receptors at the nociceptor and affect the signal that's being sent across the nerve. Right now, researchers are looking at a number of these mediators and their counterparts in the nociceptor to determine if altering the mechanism of action of these can allow for the development of new analgesics. One example of this is the voltage-gated sodium ion channels NaV1.7 and NaV1.8. We know that NaV1.7 is a key player in the initial transmission of action potentials. So any medication that can block these channels may have a great potential to reduce pain. Its cousin NaV1.8 also has an effect on action potential, and it's found in the Purkinje fibers of multiple sclerosis patients. So ongoing research into NaV1.8 channel blockers is going on because it not only may give us a new analgesic, but it may allow us to treat the symptoms of MS. Dr. Harrell has spoken about nerve growth factor and the TrkA combination. NGF is a pro-inflammatory mediator that contributes to glial cell activation and central sensitization. It also influences the sprouting of new nerve fibers that act like neuromas and are much more likely to fire ectopically and cause pain. NGF is actually found in the synovial fluid of arthritis patients, but not in their non-arthritis controls. So if we could block the interaction of NGF and TrkA, this would allow for the reduction of sprouting and reduce central sensitization, allowing for effective control of chronic arthritis pain. I wish I had more time to do a deeper dive into this, but I do want to show you some of the other targets that research is currently looking at in terms of new pain therapies. P38 is a mitogen-activated protein kinase that's activated in spinal glial cells and affects neuroplasticity. P2X3 receptors are activated by ATP during injury, and they play a role in chronic neuropathic pain. We know that the cannabinoid receptors CB1 and CB2 are found throughout the body, and their modulation of chemical messengers to influence homeostasis is being examined as a possible analgesic. Last but not least, we know that there's already been ongoing investigation of the effect of tumor necrosis factor alpha in RA and CGRP in migraines. So in summary, we know that activation of the pain pathway can lead to both peripheral and central sensitization. We know that when there's an injury or an inflammatory process, that inflammatory soup gets activated, including prostaglandins, cytokines, and nerve growth factor, and these all drive peripheral sensitization. These sensitized nociceptors can release neuromodulators into the spinal cord, which causes central sensitization, and because of the complexity of the pathway and the receptors and the modulators involved, this provides multiple targets that are currently under research to provide for new analgesics. I'd like to move on from the research opportunities that are out there to helping to form a better relationship with your patients. We're going to talk about best practices in setting goals with your patients, communicating with them, and working with your patients towards individual goals. We know that chronic pain is more than simply a physical phenomenon. Chronic pain is a multifaceted disease that encompasses the biological, the physical, and the psychological domains. If you're going to set effective treatment goals for your chronic pain patients, those treatment goals have to be comprehensive and cross all three domains. One of the ways that we can start to look at this is in terms of a patient's pain trajectory. Knowing and understanding the trajectory of a patient's pain can help to guide both goals for treatment and even the treatment itself. As clinicians, we need to address not only the trajectory and variability of a patient's pain, but the trajectory in which the pain is beginning to present. Low back pain in particular, we know that it's been recognized that chronicity of low back pain doesn't necessarily mean constant pain. There can be patients who have chronic low back pain, but they don't have a constant course. It may be remitting and relapsing. It may be constantly progressing and getting worse. It may vary in terms of its intensity and its severity. It is hoped that further research into things like the intensity, variability, and change pattern of these pain trajectories is actually going to give us a diagnostic tool in terms of phenotyping this pain and allow us to improve our ability to provide specialized treatment. This is a study that was published in February 2017. This is about depression and mood trajectories. As with our physical symptoms, we can also see the trajectories of patients' progression in terms of their depression and mood symptoms. This was a study of the Osteoarthritis Initiative, which is an ongoing longitudinal cohort study of patients with OA, measuring the risk factors and natural features of OA. They identified 5 different depression trajectories in patients with osteoarthritis, and it was noted that over 83% of patients with osteoarthritis suffer from depression as well. Taking that one step further, there was actually a study that was published in 2018 that checked the association between osteoarthritis pain, physical function, and depression. What the researchers found was that at least 20 to 50% of the symptoms of depression and physical function were mediated by pain. In other words, the pain component of their lives affected their depression and their physical function by at least 20 to 50%. So we know that aggressive and effective pain treatment can not only reduce pain, but it can positively influence physical function and can reduce the symptoms of depression. We do know that there are common factors that are associated with worse trajectories in terms of both pain and function. Patients who have higher BMIs, lower education, lower social class, patients who passively cope instead of using more active coping strategies, patients in poor general health, the presence of multiple comorbidities, and the presence of things like anxiety, depression, bipolar disorder can all contribute to a worse pain and function trajectory. In terms of patients with knee osteoarthritis, if they have concomitant hip pain, if they have joint space tenderness at the knee, if they have decreased range of motion with flexion and higher osteophytes, their trajectories are also going to be worse than patients without these characteristics. In terms of outcomes and in terms of progression, we know that pain is a major factor when it comes to knee replacement. This was a 2018 study of 161 patients, some of whom had double knees, so it was a total of 181 knees that were studied. They took a look at their baseline scores and their radiographic findings at baseline, and then they compared them prior to knee replacement. Despite the factor of whether or not they had mild OA, severe OA, pain seemed to be the driving factor, because whether they had no OA or severe osteoarthritis on initial imaging, both groups had statistically significant increases in pain immediately prior to their knee replacement. Now that we understand how all of these kind of intertwine, I'd like to move on and discuss the patient-provider relationship. The patient-provider relationship is certainly complex. Effective communication is essential to assessment and goal setting. And in this model here, this is a conceptual model of the patient-practitioner interaction. If we take a look at the outlying circles, these are what the clinician and the patient bring to the table in the interaction in terms of their expectations, their understandings, and their beliefs. The interaction circle is where those beliefs and those understandings have to overlap. And what happens is that there has to be an effective interaction. Each side must take into account the beliefs and the understandings of the other, so that a strong, confident relationship can be obtained between the two. The top box talks about the contextual factors in which this interaction occurs, and the bottom box is what happens with the visit outcomes. Note that clinician experience and patient experience are both cited there, and clinical outcomes actually comes right after that. So in terms of places that we can improve as providers, there was a 2018 article published in Pain Medicine that took a look at 39 studies in health communication. And what they found was that there were consistent barriers to effective communication that were identified. They included a mismatch in treatment goals, which I'll talk a little bit more in detail about, how much the patient and the practitioner understood the pain. And that's not just understanding the physiology. How much did the practitioner understand the patient's pain experience? How much did the patient understand what was going on with them? How much had they been taught about their pain, about the etiology of it, about the physiology of it? Also, were patients being given the tools to self-manage? And it was felt that patients needed more tools to self-manage their pain early on in terms of their evaluation and treatment. Last but not least, there was a lot of support for creating a very positive, strong relationship between the practitioner and the patients. And what we find is that when you take a look at pain patients' goals and you take a look at practitioners' goals, they can often vary greatly. This was a study that was done in 2017, and they talked to 87 patients with chronic pain that were receiving opioids for musculoskeletal pain, and they talked to their primary care resident providers. All of the residents had at least 1 year of residency under their belts. They were all asked to rate 5 goals based on importance, and these were goals that included things like reduction of the patient's pain intensity, improvement of their function, reduction of side effects, diagnosing the cause of the patient's pain, and enjoyment of life. When you talk to the primary care residents, their priorities were all improving function and minimizing side effects. But when they talked to the patient's goals were pain relief and a definitive diagnosis. Many of the patients didn't feel that they knew what was going on, and they wanted a definitive diagnosis, something that they could understand so that they understood why they were having the pain that they were having. When it comes to self-management of pain, we always try and have our patients take control of their lives. We try and have them do the things that they need to do to manage their pain as outpatients and manage their lives. There was a Scottish study that was published in 2017. They took a look at 18 different focus groups. They sat them down and they discussed barriers to self-management. They talked to numerous patients, and what the patients said was this: they didn't feel as if they got early enough education on how to self-manage their pain. They felt that they came very late in the discussion, and they felt that the communication issues with their providers were significant. They felt like primary care providers needed to improve their ability to listen and their ability to understand the impact that chronic pain had on these patients' lives. Another realization was there was some point in time where this patient and this provider came to the realization that this was going to be a chronic issue, that this was not going to be something that was cured. And this was a source of major disappointment for both the patient and the providers. The patients felt as if there was nothing left for them to do, or they felt significantly disappointed, but the primary care providers felt as if they had let their patient down. So going back to Dr. Harrell's slide about dissatisfaction between patients and providers, this may be the source of some of that, because when we realize that this is going to be a chronic issue, there has to be some kind of realization and understanding of that. And as providers, we need to help our patients get through that. They also noted that a lot of times there were limited treatment options. Patients thought that primary care providers tended to go immediately to drugs without offering up treatment options. Primary care providers agreed, but they said, hey, that's kind of been our paradigm, that's been our standard, this is what patients expect us to do. The last one is that of organizational constraints. Long waits to see specialists, long waits for tests or procedures, and a lack of holistic interspecialty management, where all of the people on the patient's team were communicating and were working in concert to get their pain under control. The Osteoarthritis Research Society International recognizes both self-management and education as appropriate and beneficial interventions. Their 2014 recommendations for non-surgical management of knee osteoarthritis were based on 2 meta-analyses and 2 randomized clinical trials. They recommended that education about self-management can be provided in either a shared medical visit or in telemedicine type visits. So what do we get when we educate our patients about pain? What do we get when we actually teach them the physiology, when we teach them the anatomy, when they give them the same kind of understanding that we have about their pain? Well, based on 13 randomized clinical trials, we found out that by educating patients about their pain, about the physiology, about the etiology, great things happen. Patients' pain scores decrease. Patients catastrophize less. They're less fearful of movement. They decrease their utilization of health resources, and they manage better on their own. Education is power for chronic pain patients. So how do we define an effective practitioner-patient partnership? Well, in the study here, they used a questionnaire called the Patient Partnership in Care Questionnaire. It has 16 items, and the first 11 items ask patients to rate their providers on things like the ability to provide the patients the information they want, whether or not providers, quote, really listen, and whether they understand the patient's personal situation and the effect that chronic pain has on them. The last 5 items on the questionnaire ask patients about their confidence in their ability to self-manage their pain. It's been found that if patients rated their providers highly on the first 11 questions that involve communication, being able to provide information they need, and an understanding of their personal situation, they scored highly on the last 5 questions that were related to self-care. There is instruction for providers out there. The Agency for Healthcare Research and Quality has developed a curriculum for providers who want to get better at shared decision-making with their patients. The SHARE approach has patients that actively seek their participation, act as kind of guides in terms of the patient's treatment options, do an assessment of your patient values and preferences, reach that decision on treatment with your patient, and then evaluate the decision that you and the patient have made collectively and determine that plan. So now, not only in terms of a comprehensive approach to chronic pain management, now includes elements on patient education and self-management, as well as our use of non-pharmacologic, pharmacologic, and interventional options. So in the time I've had with you, we've looked at the multidimensional nature of chronic pain, the importance of goal setting across multiple domains, educating patients about self-management to improve outcomes, and shared decision-making. I have been fortunate enough to work in pain management for nearly 20 years. I am certainly not naive enough to believe that all of these can be implemented in a single session. I know that my colleagues in the primary care realm have 10, maybe 15 minutes to see a patient. And putting some of these into place is going to involve breaking down some barriers. But knowing that these kind of concepts improve a patient's quality of life, they improve a patient's ability to care for themselves, and they improve their ability to actually reduce their dependence on the healthcare system. Hopefully we can start to look at, as opposed to saying, no, we can't do this, options in terms of how can we do this and find ways to make it happen. I am very grateful for your attention and very honored to be able to present here today. I would ask that if you could please continue to complete your evaluation forms as the program proceeds, and if you could get any question cards to our colleagues that are circulating around the room, we'd certainly appreciate it. And I will yield the podium back to Dr. Harrell at this time. Thank you very much.
Okay, so thank you, Scott, for really emphasizing the importance of a physician or provider-patient relationship. I think when one deals with chronic issues, particularly if something like pain, chronic pain, that's subjective, it is imperative that there be a relationship between the patient and the physician. So we're going to go through a case. I wish that we could have a group discussion, but we can't. But I'm just going to present an imaginary patient and highlight some of the things that Scott and I spoke with in terms of optimal chronic pain management. So we've got this 55-year-old woman. She is obese and sedentary. She has a history of depression, sleep apnea, and hypertension. Her hypertension is well controlled on medicines. She has a history of a peptic ulcer. She has pain in and around the left knee. The patellar fibular joint and the tibiofibular and patella fibular components are involved. Her medicines for her pain include over-the-counter acetaminophen, over-the-counter non-steroidal anti-inflammatory drugs, and over-the-counter nutritional supplements, specifically chondroitin sulfate and glucosamine. So, first step, if she comes into your office, these are the things that you would do optimally. You'd further assess her pain and the pain characteristics. Back in medical school, we knew how to do a complete history and physical, back to basics in terms of asking patients about their pain. Where does it hurt? How long has it hurt? What makes it better? What makes it go away? In addition, even if you had more time, or you should address the other issues of how pain affects their life, not just the nociceptive stimulus of a knee that hurts, but you can ask a simple question. How is this affecting your life? How is the quality of your life made worse by this pain? Engage her in some aspect of her pain experience beyond the specific nociception and pain that she experienced. You should educate the patient on her pain once you've derived at a diagnosis. I also want to say it's my opinion that often middle-aged women who are obese get ignored in terms of their pain experience. It's often attributed to arthritis. It may or may not be. So you need to perform a complete and thorough history and physical to find out if there's some other cause for her pain, which would lead to some other therapy. So assuming she's got arthritis pain, osteoarthritis in her knee, you educate her on pain and managing that pain. You don't need to be complex about it, but you need to educate or tell her about certain aspects of pain and how pain can be modulated by herself, by the patient. And you should understand the patient views on what she wants to control her pain, what non-pharmacologic things that she would like to do for her pain, what drugs she would like, what drugs she'd like to avoid, and also how she feels about surgery. And through this conversation or series of conversations, you should develop shared treatment goals. And your shared treatment goals, for example, could include reduction of her pain, self-management of the patient's pain, avoiding opiate usage, increased function and physical activity, and weight loss. So these are goals that you've come to agree on together. So in terms of non-pharmacologic interventions for her knee pain, you could suggest joining community weight loss and exercise programs. Parenthetically, the Arthritis Foundation or other community groups have specific exercises, aqua exercises to help alleviate arthritis pain. You could refer her for psychological treatment. Cognitive behavioral therapy has been shown to be useful for coping with chronic pain. And also potentially refer her to physical therapy so she could strengthen the structures around her knee and just work on achieving more optimal fitness. In terms of pharmacologic interventions, you could consider, again with collaboration with the patient, to consider the acetaminophen and the non-steroidal anti-inflammatory drugs. Because of her history of peptic ulcer, you may want to, after you've done an effective risk assessment, consider the use of a specific COX-2 inhibitor, or the addition of a proton pump inhibitor. Consider intra-articular steroids. And because it's a patient's preference and most treatment protocols for chronic pain tend to avoid the use of opiates, you will avoid opiates because that is her preference. And going down the line, considering if she has knee osteoarthritis, consider surgical options, such as a total knee replacement, if her pain and symptoms become disabling. So to summarize, between Scott and I, we've discussed that there are numerous guidelines to deal with chronic pain conditions. They all suggest multimodal treatment. They consider that is non-pharmacologic, pharmacologic, and interventional treatment if appropriate. But there are barriers to application of these guidelines. They really don't translate well into clinical practice. So unfortunately, chronic pain patient receives suboptimal care. But there is a way forward. You can engage your patient with education and resources, with societies and disease-related organizations. They have wonderful patient education materials, some of which you've seen. Again, there's ongoing research looking at both pharmacologic and non-pharmacologic pain treatment, particularly targeting mediators of pain of nociception in the periphery. And lastly, and I believe most importantly, you should collaborate with your patient with a dialogue so you can have an effective relationship and a collaborative effort and self-management of the patient with the chronic pain problem. So this concludes our presentation. So now we have questions.
Are we up and running here? Okay. The first question I have here is, what pain modalities do you recommend for someone who has had back surgery, which has led to disability, on pain meds, and would like to reduce the amount of narcotics on? Is CBD an option? Is electrical stim an option? Is TENS an option? I will tell you that, thank you. This is more of a clinical disease lecture. I don't believe we can actually make any particular medication recommendations today, and I'm sorry. I do apologize for that. I think that there are a lot of non-medication modalities out there. Two that are mentioned here are E-stim and TENS. I think if you've got a patient that's on high-dose opioids that wants to reduce those opioids, that is amenable to any sort of non-pharmacologic treatment, I think that anything, especially given the multifaceted nature of chronic pain, especially back pain, I think any trial of any sort of non-pharmacologic is worth it. I think I had mentioned, I believe, pharmacological phenotyping, which is essentially finding out which medications work for the patient and kind of making a determination of the nature of the pain that they're having. So I think you can also do essentially modality phenotyping. In other words, if we try E-stim, if we try TENS, if we try other modalities and they work, well, we must be onto something, and that kind of gives us a jumping off point in terms of the nature of the pain itself as well. Any thoughts? I have another question here. A patient comes to the office with a BMI of 40 or 50, taking opioids 4 times a day. Any suggestions? Well, I think, at least from my standpoint, the first question is, what are that patient's goals for care? Are they caught in that loop where they have chronic pain, they're afraid to move, they can't exercise, they're gaining weight? Are they depressed? Are they using eating as a coping strategy? Are they doing things to help themselves, or because of their symptoms and because of their pain condition, are they doing things to harm themselves? I think for this patient that comes in, they're on opioids 4 times a day. Their BMI is very high. They're probably in a cycle where they're afraid to move because of pain. They're gaining weight. That inhibits their ability to move or exercise even further. It may increase their pain. I think that this would involve, in my humble opinion, and again, I will defer to you, but sitting down with that patient and developing their goals for care. And I think when we talk about those goals of care, it can't just be, I want to be pain-free. We have to develop those across domains. How is this pain affecting you? It's depressing me. I don't want to get up. I don't want to exercise. I'm afraid to move. Okay, how can we work with that? Where can we go, and how can we get you started on things and modalities and maybe other medications, non-opioid meds, that will help? So I think where I would go here is, I think a very heartfelt discussion of where the patient is, how the pain's affecting them, and where they want to be and what their treatment goals are will lead to some pathways that will allow you to pursue non-opioid treatment.
So a question, what is the best way to determine the optimal combination of pharmacologic and non-pharmacological treatments for a given patient? I would think the best way is basically trial and time. I don't want to say trial and error, but you can attempt non-pharmacologic treatments such as exercise, physical therapy, and if the meds are taken on an as-needed basis, you may find that the patient is taking the medicine less frequently. Anything to add?
No, ma'am. I think that summarized it perfectly.
Yeah. Another question, is there a defined time period for acute versus chronic pain? Acute pain tends to last less than 3 months. Most of the guidelines and literature defines chronic pain as pain lasting at least 3 months in duration, and or longer than the expected time for an injury to heal. For example, if you've had a large back surgery, you might have pain longer than 3 months, but if your surgeon in his or her experience says, oh, you should be pretty much pain-free in a year, you wouldn't call, the eighth month mark, oh, you've got chronic pain. So 3 months tends to be not necessarily the cutoff, but looking at 3 months, you probably potentially have chronic pain. Again, you have to look at the etiology of the pain. Is there pain after a surgery? Did it just happen spontaneously? Is it nociceptive versus neuropathic?
What is your feeling about the use of CBD oil as an adjunct to pain management? Well, that's a slippery slope. That's I think the jury's still out on a lot of this. This is what I can tell you. There's a gentleman by the name of Michael Shatman. He's a PhD psychologist over at Tufts. And back in 2014, when the National Academies of Medicine released sometime in the 2000s, the National Academies of Medicine and Science released their report on cannabinoid-type products. Now, the problem is that they lumped them all together. And they took a look at about 4 studies that they felt met their criteria. And they said, okay, these may be helpful in terms of pain management. But Michael Shatman came along and he said, okay, I'm going to build on that. And as the use of cannabinoids has flourished, we're starting to see more and more research out there. And some of that research is contradictory. According to Dr. Shatman, essentially for things like osteoarthritis, musculoskeletal type pain, there is no conclusive evidence that they have a statistically significant difference. For cancer pain, again, no conclusive evidence that there's a statistically significant difference. The only place that they found that cannabinoids, and remember, we're not talking just about CBD, we're talking about cannabinoids across the board here. The only place that they found that there might be a difference is with neuropathic pain, but there's never been a head-to-head study of cannabinoids against gabapentinoids, which are kind of our standard of care for neuropathic pain for this. So the jury is really out here, and I think what we need to do is we need to do more research on this. And the question becomes, for me, given the effects of cannabinoids in the system, given their effects on homeostasis, given what they do and how they do it, are we treating the pain? Are we treating the anxiety? Are we treating other symptoms? Remember that I talked about pain being a multifactorial biopsychosocial experience. And we know that the psychiatric component of that is huge. So is it the fact that maybe the CBD is working on something else, not directly on the pain? Is it working directly on the pain? So I think the jury is out. I think we need more research. But I will tell you that everything that I have seen up to this point, everything that Dr. Shatman has seen up to this point, he's kind of my go-to guy for this information, says not a whole lot of statistically significant evidence supporting this. The only place is really neuropathic pain, and it's never gone head-to-head against gabapentinoids.
We have time for perhaps one more question. I'm going to combine 2 questions and give a brief answer. First question, why are NSAIDs so quickly prescribed, recommended without consideration of deleterious side effects and GI bleeding and renal impairment? And also, regarding osteoarthritis pain, why do guidelines still recommend acetaminophen? It's a weak analgesic and bears the risk of liver toxicity. It's easy to get a lethal dose over the counter. There is no panacea. These drugs are some of what we have for pharmacologic manage of pain. I think it speaks to the need for a multimodal approach with other non-pharmacologic agents. And with regards to acetaminophen and NSAIDs, they are over the counter, but they do, like any drug, have side effects. The recommended that you don't take too much acetaminophen at any given time for the potential of liver toxicity. You don't get anything free, but you need to monitor your patient's use of acetaminophen as well as NSAIDs. In recent years, we found contraindications and risk for particular non-steroidal anti-inflammatory drugs. So again, you have to monitor your patient and realize that there are certain contraindications and relative contraindications to the use of these drugs. And I'll circle back and say this speaks to the importance of having a collaborative conversation with your patient so that you're aware of what drugs they're taking, how much, and when, so you can be aware of the potential for side effects. I think we have time for one more. It's now 12:30, so I think we'll wrap up. Thank you so much for attending. Don't forget, please fill out your evaluation to help improve programs in future years. Thanks again. Oh, thank you again.
Doctor,
Look at
thank you.
you.